Well, welcome. It's 7 o'clock. It's Monday, and so it's time for the next in the series, COVID-19 series of webinars. And tonight, it's a particularly important one. We're looking at the recovery phase for trauma and orthopedics, and what a huge logistic challenge that is. And we've got some absolutely fantastic panelists and a chairperson to look after you. But before I introduce everybody, I just want to tell all our members and fellows about what's going on at the college. It is open virtually. We are running all our committees and all our council meetings. Indeed, 10 days ago, we had our main council meeting for June rather, and they have gone very smoothly, as we're demonstrating with our webinar tonight with Zoom. As well as that, we're preparing for exams. The MRCS and FRCS exams have been suspended up until now, but the college is preparing to run these exams at the late part of the year, October, November, December. That's all depending on where the pandemic is and what government guidance is. But hopefully, with social distancing, we will be able to run those exams. And of course, there's a logistic problem in getting all those who were logged in to have those exams all set up to get those exams for them. The college is open for support and help. You just have to either call in or email in, and we will answer that. And of course, education is ongoing as well. This is the 25th in the COVID-19 series of webinars, and there is a whole host of other webinars running during the course of the week, particularly for medical students and FY1s, which has been very successful across the piece. So please use that facility. Apart from that, we're open for business as I described. So without saying anything further, I just want to say that we've got a great panel here. We've got Wilson Lee, President-elect of Hong Kong College of Orthopaedic Surgeons. We've got James Murray from Bristol, consultant surgeon there, past director of trauma in Southmead. We've got Phil Turner, celebrated knee surgeon and past president of the British Orthopaedic Association. But important person first now, it's Claire Edwards, who's consultant orthopaedic surgeon at the Norfolk and Norwich, and she's chair of the Trauma and Orthopaedic Specialty Board here at the Royal College of Surgeons of Edinburgh. And I think this is going to be an absolutely fabulous session, and I'm looking forward to it. So I'll hand over to you, Claire, to actually interview these great panelists properly, better than I could do. Claire.
Thank you, Mike. So it's my pleasure to be able to chair this meeting tonight. We've got some great panelists, each with their own expertise and knowledge of what's going on with the COVID epidemic. We're going to hear from each of the speakers in turn, and then at the end, I'll be putting your questions to them. So continue to ask questions over the Zoom functionality. First, we're going to be hearing from Professor Phil Turner, and he's been instrumental in providing a lot of the BOA guidance on how to manage recovery in following the COVID pandemic. So we're going to hear from Phil Turner first.
Okay, thank you very much, Claire. So what I'm going to cover very briefly is just the development of guidelines, prioritisation and the early progress in the UK towards trying to re-establish scheduled surgery for orthopaedics. Now, it's some weeks ago that Simon Stevens really put forward these two statements in a letter to the NHS in the UK, and I'll direct you to the second one, that in addition to establishing urgent services not related to COVID, that we should be looking at whether there is a capacity to at least start some routine non-urgent elective care. So that's just looking to see if there's capacity, not saying actually start. So to do this, the BOA produced some guidance, and I say specifically guidance and not guidelines. The evidence is developing day by day, and there have been actually surprisingly few central guidelines which really help us to address re-establishing scheduled surgery. There's also been enormous variation in the epidemiology of the epidemic, and the slide to the right from early on in the surge phase shows just how different the experience was across the regions and in the devolved nations. The other problem to trying to come out with firm guidelines is that the geography of how you provide your orthopaedic services really varies, particularly across a region where there may or may not be a dedicated orthopaedic elective hospital, across a city where there may be 1, 2, 3, or even more hospitals, each with their own subspecialties. And within a hospital, you have to consider whether you can actually create a good separate pathway for re-establishing your elective services. The guidance is predominantly cautious. As we're easing lockdown here in the UK, the initial fall that we saw in trauma, particularly related to RTAs, sport and alcohol related trauma, does seem to be reversing, and trauma is now once again increasing. And of course, we have the risk of local or national surges in COVID, which we have to be able to contain. We still need to manage emergency and urgent cases. We're not practicing disaster surgery here. We still should be able to provide appropriate surgery for our trauma, infections and tumours. And initially, we were predominantly worried about the passage of infection, COVID infection, from patients to staff. But once you start considering doing elective surgery, you do have to be more concerned about staff to patient infection, staff to staff, and patient to patient. So this is really important in establishing safe pathways. An excellent document was produced by the intensivists and the anaesthetists, and they strongly encourage, as we do, the development of a recovery management team of clinicians and managers to cover all your surgical specialties, not just for orthopaedics. And they need to establish the systems and pathways for safe restoration of orthopaedic and other non-urgent surgery. And fundamentally, they divide the criteria into the 4 S's: space, staff, stuff, and systems. So for space, do you have enough theatres? Do you still have enough ICU capacity to start working on scheduled surgery? Do you have sufficient staff? And this isn't surgeons particularly, because many orthopaedic surgeons who do purely elective surgery, I think, are feeling a bit underutilised at the moment. But we've found certainly the biggest shortages in anaesthetic nursing staff and theatre staff. You have to be sure you have enough equipment and enough drugs. And I understand there's a major problem still with propofol. And you also have to establish those systems and pathways and have absolutely immaculate infection prevention and control. For prioritisation, firstly, you need to prioritise by pathology, and a joint document by the surgical colleges together with NHS England have divided these into various priority levels, from emergency to elective surgery that can be delayed for at least 3 months. And for the majority of the elective surgery that we do in terms of hip and knee replacements, most of those are going to fall into priority level 4. But you also have to prioritise by risk, and that's by the patient's own risk. And we still find that the CDC one is still the most appropriate, with chest disease, heart disease, diabetes, obesity, the age of the patient, and being immunocompromised. And if you look at the X-ray there on the right of the screen of a failing knee replacement with rapid progressive bone loss and potential fracture out of the stem, if that's in a 58-year-old patient who's otherwise fit, you would probably want to get on with it. In an 82-year-old with 2 comorbidities, you would probably hang on and wait until the time may be safer than it is at present. So what is the risk of starting up on elective orthopaedic surgery? And I think we're all aware of the paper from China and the COVID surge paper more recently, all published in The Lancet, that if a patient's unfortunate enough to develop COVID in the perioperative or post-operative period, the overall mortality is more than 20%. But what really matters to us now is how do we prevent that? By developing a green pathway of care in a gold facility, and I'll come back to that shortly. But what we really want to know is what is the risk of performing surgery on a patient when there's lower COVID prevalence in the community, patient that's been isolated for 14 days pre-surgery, and a patient that's been appropriately screened and tested. So the key principle, firstly, is in the care pathway and the development of what we have labeled a green COVID protected pathway. So purely for elective scheduled care, where patients are screened and tested for antigen, isolated for 14 days pre-op, and recommended also to isolate for 14 days post-op. Your pathway needs to be physically separated in your hospital, and I'm sure James will come back to this, but also staff which are separated. And don't forget that all the other surgical specialties want these green pathways. It isn't just orthopaedics that wants a green pathway. So we still have to have within that a ring-fenced area for orthopaedic patients. We don't want to cope by reducing COVID complications only to swap them for having a higher incidence of normal bacterial infection. The green pathway as opposed to the blue COVID managed pathway where you're unsure of the status, the COVID status of the patient. And the second principle relates to the facilities that you have available. And the easiest one for which to get a green pathway established is in a gold hospital. And these are the typical standalone orthopaedic hospitals such as the Royal National or the Royal Orthopaedic, where you have single access points, completely separate site, completely separate facilities, and you can establish robust screening and testing with separate teams all the time, no swapping from blue to green. And all the codependencies, particularly your diagnostics, on the same site. So are we ready in the UK? In the third week of May, the BOA, together with the British Orthopaedic Directors Society and Getting It Right First Time, ran a survey of the clinical directors across the UK and in the devolved nations, but these responses predominantly come from England. 76 trusts is a good response rate. That's about half the trusts that we have. So the first question was, do we have enough PPE for theatre? And the answer now is yes. So the PPE issue, although not perfect, does seem to have been addressed. Are the patients on the waiting list being reviewed? And again, they are being reviewed. And one of the questions you have to ask is, do you want to come in for your surgery? And it would appear about 20% do not want to come for elective surgery that they were listed for prior to the epidemic. And another 20% certainly want to wait until it's as safe as possible. Do you have a specific consent form relating to the risks of COVID? And most do, but many don't. And this is really important because consent now is very different from consent that you would have obtained in February. When do you plan to start? About a third of units were planning to start 2 weeks down the line from when we did the survey. Another third, 4 to 6 weeks, but a third had no plans to start elective orthopaedic surgery at all. Where is the green pathway? Again, standalone hospitals or a standalone building on a general site were just slightly more common, but a large number of these green pathways need to be established in a general hospital. So you really have to think hard about how you're going to separate out that pathway for your patients so they're not exposed to COVID. And what about staff screening and testing? And again, daily temperature and a screening checklist are pretty straightforward, and everyone should be doing that for their staff who are going to be working in a green environment. But antigen testing on a regular basis is only available in 1/3 of the units that we're planning to start elective orthopaedic surgery. Okay, so that's just a brief overview. The rest I'll leave for the details to the next speakers. But please start putting your questions into the Q&A slot so that we can answer those when we get to the end of the presentations. Thank you very much.
Thank you, Phil. That was a great overview to the progress that the BOA has been making on providing some guidelines that are trying to fit all locations. Now, we know that COVID has come from the Far East, and the Far East has been ahead of the curve in many ways in dealing with the epidemic. And that's why we're very grateful to Dr. Wilson Lee, who is up at 3 a.m. in Hong Kong to tell us about his experience. He's the chair of the Orthopaedics and Traumatology Central Coordinating Committee in Hong Kong, of the Hong Kong Hospital Authority. So he really does know the nuts and bolts of how Hong Kong has been dealing with the pandemic and how they're trying to recover their services. So I'll hand you over now to Dr. Wilson Lee.
Right. So thank you for the kind remark there. And then I'm going to share with you in the next 10 minutes the impact of COVID-19 on the orthopedic services in Hong Kong. So the history repeats itself once again. So since December, another mysterious outbreak of viral pneumonia started in central China and threatened to cross the border to Hong Kong. So in January, we have reported the first few cases in Hong Kong. And by February, the cases has spread all over Asia, and by March has crossed the border and the continent to Europe. And by now, I think the epicenter has changed to the Americas, and almost no country in the world will spread. Armed with the experiences that we've learned during the SARS outbreak in 2003, our scientists in Hong Kong has devised a lot of preventive measures to try to limit the spread of the virus. By knowing more about the symptomatology as well as the epidemiology in devising methods to limit the spread of the disease. At the community level, we have emphasized the importance of hand washing, mask wearing, and also social distancing in limiting the spread of the virus. And at the healthcare facilities, we emphasize the improvement in ventilation as well as the appropriate use of PPE at different levels of risk patients and areas. We pay special attention to those high-risk activities such as AGP, aerosol generating procedures. And we recommend the use of the most stringent PPE in those highest risk procedures such as AGP. Actually, during the SARS outbreak, we have learned from our bitter experience, our orthopedic colleagues has alerted ourselves to the possible hazard of transmission of the virus through these AGPs. And this was echoed by health authorities across the world. And even the current international recommendation is to pay the highest level of protection of staff against AGP procedures. However, we also recommend the prudent use of PPE according to the different stress or risk levels. Together with the policy of social distancing, there are several impacts on orthopedic service delivery in terms of manpower, delivery of surgical activities, outpatient activities, and also indirect services such as medical assessment boards and education, as well as training. Some of our medical and nursing manpower were deployed to the screening facilities and isolation facilities to tackle with the outbreak, thereby limiting our manpower at work in orthopedics. We also make a major cutback on elective surgery services in orthopedics, except those tumor and trauma surgery. And even still performing such surgery, we try to reduce the personnel present in the operation rooms to the bare minimum in order to minimize the usage of PPE. We also try to outsource some of the so-called simple trauma cases to our private hospitals. When surgical procedures were performed, the preferred mode of anesthesia would be spinal, local, or regional anesthesia in order to both reduce the in-hospital stay time as well as minimize the usage of PPE. For those cases that has been postponed, we recommend to consider temporizing pain relieving measures such as image-guided nerve blocks or injections. If surgery has to be provided for those confirmed cases, we will dedicate a special orthopedic contamination team to work so as to minimize the risk of cross-contamination. And for inpatient consultations, we will recommend our staff to wear the appropriate level of PPE. At the outpatient level, we also try to lengthen the interval of follow-up by either utilizing telemedicine for consultation, or we can just ask the relatives to come back for drug refill without actual patient consultation. When the patients do come up at the clinics, they will be screened according to the FTOCC criteria. And throughout the encounter with the patients, we will use the universal precaution, paying special to hand hygiene procedures in between patients. For the less essential services like the medical assessment boards, these are all suspended. More indirect impact will be on training and education. Since all inter-hospital face-to-face activities were suspended, we will try to employ the advances in information technology such as video conferencing to compensate for the loss of exchange activities. Even the conjoint examination with the Edinburgh College as the exit fellowship examination has been postponed. We try to compensate for the relative lack of interactivity of this video conferencing by follow-up of the faculty with online discussion. And we also made significant changes in terms of the requirement for training points and surgical logbook statistics by the trainees. In March, the disease was declared in pandemic. By April, it seems in Europe and Asia, the disease has peaked. And by May, supposedly, we have entered the early recovery phase. In Hong Kong, the hospital authority has declared that we should resume slowly, phase by phase, all the clinical activities that has been suspended as a result of COVID-19. But the first criteria or prerequisite will be to review the use of PPE. We try to review both the demand and supply. For the demand side, we'll ask our anestheticists to consider designated induction team so as to conserve PPE. And on the supply side, we try to increase the local developed PPE such as using 3D printing technology. We also review the guidelines according to the possible AGP and also wider application of the rapid and reliable diagnostic tests. So our strategy is to resume elective surgical activities in phases. First, we resume those procedures that can be carried out under local, regional, or spinal anesthesia. Another priority area will be those surgery that aim to restore neurological function, such as spine surgery and nerve decompressions. Taking into account also the availability of essential supporting services, such as manpower, bed number, as well as blood products. We also use two schemes to try to support or avert the relative lackage of manpower. The SHS stands for Special Honorarium Scheme, whereby we will hire our public hospital workers to work on extra evening and weekend sections to clear up the backlog cases, both in the OT and the OPD. We also involve our private colleagues by either outsourcing some of these procedures to private clinics, or we'll hire them as locum doctors to work in the public system. Another area is that we think video conferencing is something to stay on, and we'll try to solve the anticipated problems of patient privacy issues, as well as the lack of interactivity. Some guidelines adopted internationally, such as these by the American Academy, are useful in resuming surgery by prioritizing the level of urgency of different orthopedic procedures. This results from the important discussion by the American Academy and published in 2 JBJS journals. Concerning the use of PPE, as well as when and how to resume elective surgery. For example, the 6 Ds has to be considered, namely the disease pattern, diagnostic capabilities, delivery of care and PPEs, design modification, disease detection, and disease defense. They even come up with a PORE score to try to stratify the risk of performing elective orthopedic surgery, taking into account the contraindications, the anticipated resource requirement, as well as the patient demographics. A PORE score of over 15, procedures should be suspended until a vaccine is developed. In terms of the use of video conferencing and other IT help conferencing, I think this is something going to stay, and this will actually ease the access of medical care. More importantly, we should consider change of the model of care. For example, we should increase the utilization rate of day case surgery, as well as increase our output in the single specialty orthopedic hospitals, the so-called stand-alone orthopedic hospital facilities. At the present moment in Hong Kong, with only one for adult patients and another for children. We should also consider redesigning our infrastructure in the hospitals and readjusting our workflows so as to minimize intra-facility disease transmission. So, all in all, I think what we need is a paradigm shift. We need to adopt a new model of care. For example, VR, AR, or even mixed reality. We also need to increase the output by the ambulatory surgery centers and single standalone orthopedic hospitals, and perhaps re-engineer our perioperative care. We should also consider adopting to a wider extent the new model of communication using the advances in IT. Thank you.
Thank you, Wilson. That was a very illuminating talk. We will endeavour to make sure that the slides are shared on the recording for everybody to enjoy. So we had a lot of useful information there about how Hong Kong has been managing things, and they're clearly a bit further on in their planning. But we've now got some centres in the UK that are starting their elective services, and one of those is Bristol. So it's my pleasure to welcome James Murray, who's been leading the restoration of elective orthopaedic surgeries in Bristol. Over to you, James.
Thank you very much, Claire. So hard acts to follow, really. What I'm going to talk about for the next 10 to 15 minutes is a summary of what we're doing in Bristol, and is a much more simple approach rather than a high-level approach like the excellent reviews that we've just heard from Phil and Wilson. So there are no relevant disclosures, and I'd like to thank the whole neuro and musculoskeletal division, in particular Nick Smith, Divisional Director, Stevie Waring, who's the Assistant Acting Medical Director, and Mel DeVitt, who is the matron. So we used to have a standalone gold centre. It was originally in Winford, just outside of Bristol, and then the Avon Orthopaedic Centre was a standalone building on the Southmead site. We were fortunate to have a fantastic new super hospital built, and we moved into that in 2014, and the AOC is now part of that, which of course creates a problem in the current environment. There are lots of guidelines now, but when we started, it was a little bit more sparse. The BOA guidelines that Phil Turner's just discussed are really excellent and very helpful. So what we wanted to do at the start was to have a robust process to optimize patient outcomes, of course, but to minimize the additional risk to the patient and our staff. It must allow those normal quality processes to flourish that we always do, and we minimize the transmission between patients during elective surgery, and minimize the chance of a patient being infected with COVID as a result of their elective admission. So the key principles really are that we don't want patients together. We want to separate patients and socially distance our patients. Now we have set up a green sort of COVID screened negative pathway on level 3, which is a separate zone in the Brunel Hospital, which is the main building on the Southmead site. The amber patients are unknown COVID status, and they stay on level 2. The green patients are on level 3. That's the simplified summary of the talk. Now, historically in Southmead Hospital, we had 2 separate levels. The first, level 2, was for intensive care, theatres, and the emergency care, whereas level 3 was for more elective planned procedures. Now we've got a green zone on level 3 and an amber zone, whereas on level 2, it's majority is amber, but of course there's theatres, and there is some COVID work still in theatres, but in a separate blue zone, as well as ICU. So that's separating patients, but of course we've got patients and staff. And one of the key things that we can do there is use PPE. We've heard a lot about that from Wilson, so I'm not going to dwell too much on PPE. The key principle, of course, is to minimise the risk of transmission of COVID-19 to the elective patients from the staff and vice versa. But if you're a patient and you're approached by members of the healthcare professional team wearing these masks, just bear a moment to think what it must feel like. And in a pandemic, we have to remember that many, many years ago in the Black Death, there were all sorts of horrible masks put on for the plague doctor. So this was an original way to try and stop transmission disease in the Black Death many years ago. But of course, masks can be scary, so please do remember that. Prioritisation of cases, we've heard from Phil Turner. Vital, very helpful, P1A up to P4. Our whole orthopaedic waiting list was reclassified, and and in keeping with the BOA guidance, we set up clinical surgical prioritisation groups to distribute the lists on a background of need. So we looked at the available kit and staff, and we based this on the percentage of activity per department. The staff were originally in mega teams to cope with the COVID surge, and they were released as the need decreased. It was also linked to ICU usage, in keeping with the excellent document from the Royal College of Anaesthetists, the 4 S's that you heard from Phil Turner, and also anaesthetic drug requirement, which was a key issue. We started with 3 lists a week, and this was on the 4th of April, and we were doing P2 cases. For hip, it was essentially prosthetic joint infection. For knee, locked knees and prosthetic joint infection that was acute. And we also set up some lists in the local treatment centre. There are 3 independent sector hospitals in and around Bristol. One is an NHS unit, Emerson's Green, run by KUK. And they were taken over under the NHS contract and were providing surgery for cancer, for breast, and for urgent urological procedures. And then we took a list, and that's now 5 lists a week from Emerson's Green. Nuffield is being developed for spinal services, and Spire originally was under BRI, which is a separate trust, the Bristol Royal Infirmary. But we are now using the 5 lists a week from within the Spire as well. So, of course, the independent sector NHS contract is until the end of June, but that's extending. Now, this week, 8/6/20, week commencing today, we have 10 lists in the independent sector, 5 at Emerson's Green, 5 at Spire. And we have 8 all-day lists within North Bristol NHS Trust on this main Brunel site. In addition, we have 2 all-day trauma lists, and that really has not been enough because we've had a significant surge in trauma demand recently, plus an all-day spinal list. So, preoperative screening, face-to-face appointment, one stop. Patients, we initially self-isolated for 7 days, but we've now increased that because the BOA guidance came out after we started operating, so we have increased that. And the patient must attend the pre-op assessment clinic now over 15 days prior to surgery to allow for sufficient self-isolation. All patients are screened for COVID-19 48 hours prior to admission. That's either by drive-through testing here or by the hospital at home team in the community. The tests are checked by pre-op, and any COVID positive patients are obviously cancelled and rebooked. We have routinely run dedicated consenting clinics here in North Bristol. This has had to be modified. We have a dedicated Southwest COVID consent form, and we also run the consent clinic virtually at present. Sometimes when we do need to see face-to-face consultation, we bring in the patient to the pre-op assessment clinic, and then the relevant consultant goes down to see the patient at the POAC clinic. So the documented consenting process is started early, but of course the form is physically signed on the day, but we've started that consenting process much earlier. Kit requesting is exactly as it has always been for us, electronically on the ICE requesting system. So our inpatient pathway, the patient is met in the atrium, temperature assessed, offered a mask, and then taken up to the relevant area on level 3. A little bit of local geography. The hospital is in 3 zones. You can see 2 of them there. There's a large atrium-based hospital, green zone at the front, blue zone in the middle, and behind that a pink zone. So this is a very busy slide. I don't want you to read it all, but this is an organogram of the wards based on amber patients, green patients, and blue patients being COVID. And this is what we did have during the initial COVID surge. So orthopaedic elective ward, the main inpatient ward was Ward 26A. The 2 other green wards were separated. So the central third of this slide is the blue tower. The left-hand column is a green tower, the front of the hospital, and the right-hand column is a pink tower. So 3 very separate areas. And what we've done is corral these down. All green patients come to a separate entrance rather than the main entrance. And they go to a ring-fenced elective care ward. No emergency, no elective non-screened patients will be on there. And we're happy to accept a very limited target occupancy. We've set the target occupancy of 50% to start with, but I must point out that most of our hospital is single room, 75% is single room, and there is a small group in 4-bedded bays. So a very unusual experience for us in North Bristol is seeing these green available beds on wards. This is a picture of inpatient rooms, and that is a 4-bedded bay. So very straightforward in terms of rooms. They're nice rooms, but of course 75% single rooms makes this much easier. Another key difference here in North Bristol is the Medi room. So there are no anaesthetic rooms. The blocks or preoperative workup is done in a Medi room in an adjacent zone. So standard respiratory precautions. The staff have not routinely been tested when we started, but now have been through antibody testing. Practical things like curtains being replaced and absolutely stringent hand hygiene and notices on doors and wards, practical things like that. When professionals start their ward round, it's got to be in the elective area and then move on to non-elective areas. And we keep separate scrubs. So blue scrubs for people who are not in theatre, raspberry scrubs like I'm wearing if you are inside of theatre. So what we did is we moved from this pattern and we corralled the green pathway patients all together on level 3. We ideally would have liked more than one tower, but we have gone for a horizontal structure. The towers do link together. So orthopaedics now on 7B with either side for both spine, neuro, and the elective general surgical admissions. Again, in terms of access in and out of the Medi rooms, this is again zoned. So I've highlighted here what was initially the red pathway, but is now the blue pathway. going into what was a dedicated COVID theatre for the blue patients. Minimising risks to staff, full PPE in theatre. We assume that patients are COVID positive, even though it's extremely unlikely. Eye protection, FFP3 masks. We are using ultra-high filtration, of course. Beware of the striker hoods, because we normally use those. We're very pleased with those, we're very happy with those, but we've not been using those in this situation because of potential recirculation of aerosol. If there is a surge, we stop and restart our COVID surge management with mega teams. So what's gone well for us so far in Bristol? Really, the way that we repurposed and had a huge expansion to respond to COVID was very positive. Massive flexibility within the workforce and a lot of input from orthopaedics in particular, which is recognised across the hospital. Interaction with the local independent sector has also been very good. If we look at our trauma experience, and I credit Richard Donovan, Tom Tilson, Brianna Frostick, Tim Chester, Mike Kelly for this data, we looked at April 19 versus April 20. There was a 30% reduction in their trauma load. Fracture neck edema, no change. Mortality was reduced, complications were reduced, but op time, of course, was slightly increased due to all the PPE constraints. All procedures had consultant present. Another thing that's gone extremely well is the support that we've received from psychology and wellbeing teams. That's been fantastic. I know that's going to be looked at in a future webinar from the RCS Edinburgh. Multi-professional triage, in keeping with the BOA guidance. Once individual consultants have prioritised their lists, we then have a proposed list, and that is then reviewed in a multi-professional format and formally recorded. Often double consultant operating or double consultant available. The consenting clinics, we are trying to use Attend Anywhere. We're hoping that that's going to be available for us soon. It hasn't been yet. In the meantime, we're only telephone. In terms of problems, there's a lack of room, potential for home working with appropriate trust laptops, but again, that's been an issue, but that is improving. And there's a clinical risk in terms of a lack of examination unless the patient's brought in for a face-to-face clinical review. We were self-isolating 7 days. We're now self-isolating 14 days. And what we've noticed is that quite a few patients have refused surgery, exactly as Phil Turner said, at 20%. But a lot of this is not due to their own reasons, often family reasons, and they don't want to self-isolate. We've been stratifying patients, modifying the CDC, and going for scores under 3 with a green score. So, what's the flip side to that? Well, there are a few issues to resolve. We need to work hard at our medi rooms, particularly toileting is quite an issue because all of the individual rooms are all en suite and separate. We've had to be very careful at distancing patients in toilets and then increasing the cleaning frequency. Imaging is a problem. We normally have 250 requests from trauma orthopaedics alone per day here. And with social distancing and increased cleaning, the imaging department say that they can only do 150 a day. We're not certain about our model and preoperative assessment for social distancing. We need to be careful with that. Similarly, our consenting clinics are only virtual, and we would like to get back to face-to-face. And in terms of PPE, it's cumbersome, it's uncomfortable, and it certainly adds a time delay. So, in summary, you need to protect your patients, your staff, and prioritise your cases. When it's safe locally and using the national guidance, then you can restart. But be careful because there's a potential for litigation, so please record stuff carefully. Thank you very much indeed.
Thank you very much, James. That was interesting to hear how things are being done in Bristol, and you're actually on the ground having the experience of how things are working. We've had a lot of really interesting questions whilst you've all been talking. They've fallen into several main themes. So we've got quite a lot of questions coming in about preoperative pathways, trying to avoid people needing surgery, testing, what are aerosol generating procedures, and staff flows are quite a big topic area that people want to discuss. So I'm going to start by asking you, James and Phil, about consenting and pre-op. Do you think there should be any guidelines for choosing who's going onto our lists going forward? So we're being asked by our commissioners to see increasing numbers of patients in outpatients. How would you be happy having somebody come to your consent clinic as the first point of call with you?
So the first time I've seen them, that happens quite a lot actually for us, and that's one of the reasons that we've always run a separate face-to-face consenting clinic. So if an ESP or one of my colleagues has put someone on the list for, let's say, an ACL and a meniscal repair, we've been doing this afternoon, then I'd see them for the first time in the consenting clinic.
Right.
So that's quite a standard practice, but it is a face-to-face proper clinic. There's time, the patient's carefully examined, and we were very happy to change operations, for example, if they've been listed for a total, and then I think they're more appropriate for a uni, then I would make that decision there.
How does the panel feel we should handle high-risk patients who are on our waiting list? So, for an example, you've got a man who's 65, he's got mild asthma, and he's slightly obese, he's got a BMI of 40. Previously, he'd have just been listed for a knee replacement as per usual, not felt to be particularly high risk for our patient population. But suddenly in the COVID era, he's a high-risk patient. Does he get to choose whether he wants to stay on your list, or do you decide that he's too high risk to do it at the moment?
Yeah, I think it's a difficult one. I mean, it's got to be informed. You have to inform the patient what the risks are. And in fact, most patients who have any risk factors are extremely nervous about coming into hospital anyway. So I don't think actually trying to put patients off by explaining to them what the risks are is actually the problem. From my experience, it's almost the other way around, that patients who you really think should come in because they're going to struggle or suffer serious complications if they don't have the surgery, it's almost trying to reassure them that you're doing everything you can to allow that surgery to proceed. So I don't think it's that big an issue of putting them off. And I think if if it is a high-risk patient, then yes, you've got to discuss the risks. You've got to inform the patient, but it isn't ultimately the patient's decision. It's a joint decision, but you've got to take the lead.
Thank you. We've had a few questions about managing patients in settings that aren't the ideal green or gold setting. So if an informed patient is looking to have a cruciate ligament reconstruction performed, and they're aware that there's a risk of COVID, and they're aware that your facility isn't green, would you still be happy to go ahead with that surgery?
Right. So, I mean, I think we just need to get the colours sorted out. So the green is the pathway that you're actually going to manage the patient on. And it is easiest to establish that green pathway if you have a gold unit or a gold hospital in which to perform it. So I think you just got to separate those two things out. I think many places are going to have to work not in a gold environment. That was clear from what we did. At least 2/3 are not going to be able to provide that gold facility. But you have to provide the green pathway. There is no argument about that. And I think you cannot compromise on that for elective surgery, because the outcome is so terrible if the patient develops COVID post-operatively. And that seems to be the case, even if it is what you would think of as being relatively minor surgery, such as a day case ACL reconstruction. If they develop COVID 2 or 3 days afterwards, they're in serious trouble.
We've had another question from a clinician asking, they don't feel their situation is safe to recommend selective surgery. However, their management are pushing them, and how should they be advised to respond to that?
Well, go on, James. You have a go.
Well, I think it's very simple, isn't it? If they are not safe, then ultimately we have to be safe. So if the clinicians do not feel safe to treat patients themselves, for both protecting their staff, but more importantly, protecting their patients, then it's a no. If there is a safe pathway, then it's reasonable to proceed, but not until. So it has to be in conjunction with the management team, and there should be a strong buy-in from the clinical managers within the department to organise that. I think there are lots of examples where this is happening across the country, and so if there is not, if there's a reason that it's not safe, then, and your management team are pushing you, then look for advice. Get somebody else from outside to come perform an external review.
That's good advice.
Totally agree.
We've had a lot of questions about patients who either don't want or can't have surgery at the current time, but are in an enormous amount of pain, and there are all the steroid injections. Are they safe? How can we make them safe? What should we be telling patients around steroid injections?
Yeah. So this has become quite controversial in the UK. I'll be interested to see what your thoughts are about steroid injections and their use. The original document that came out conflated all uses of steroids, including intravenous, intramuscular, oral, and the local injections for musculoskeletal pain, such as what we're actually thinking about. But if you separate them out, then if you've run out of all other options to relieve pain, then you explain to the patient there is a potential increased risk of reduced immunity if they're exposed to COVID, or getting a poorer outcome if they do develop it, but you have no other alternative, then it is actually okay to go ahead. It's a matter of that informed consent, but this has somehow got interpreted in the UK as being a blanket ban against using intra-articular or soft tissue low-dose single steroid injections. So I think, and the document is about to change in the UK, so I hope it'll come out this week. I've just been going over the final version this afternoon.
Dr. Lee, what's happening in Hong Kong with regards to steroids?
Well, I think the situation is more or less the same, because patients, I think they have a lot of anxiety on having musculoskeletal injection for steroids because of the possibility of further compromising their, the immunity, and thereby may have an increased risk of getting the infection. But then we also witnessing a trend of injection of orthobiologics, such as PRP in Hong Kong as well. So the patients are also given this option. So we are, out of those patients that have their surgery cancelled, so we are giving actually this option to the patient. So either injection of the biologics or injection of steroid, and the patient will consider the risk themselves.
Okay, thank you. So again, the next step up the pathway, we've just had a question from Tim Hems about going on to maybe use local anaesthetic procedures or regional anaesthetic procedures. How do the panel feel those fit into our current stratification of risk for COVID? Can they go through less stringent pathways?
Right. Well, if you look at the COVID surge paper and the paper from Wuhan, unfortunately the answer is no. If they develop COVID post-op knee replacement done under spinal, they're just in exactly as much trouble as they would have been if they'd had a general anaesthetic for their knee replacement. I think what you have to separate out is also the concern about aerosol generating procedures with this. Giving a general anaesthetic is undoubtedly an AGP, and particularly an AGP for the anaesthetist. But there's actually increasing, not exactly argument, but a slight move. And again, I'll be interested, Wilson, with what your experience is. about whether using high-speed drills and saws is actually an aerosol generating procedure in orthopedics for what is probably a very minimal, if any, viral load in bone marrow, blood or soft tissue in a patient who's gone through all the green pathway before they get there. And there has been an evidence review that's come from Scotland, which is seeking to actually remove the orthopaedic AGPs, if you like, from being in the AGP risk list, which would really have a major impact on PPE use and throughput in theatres. But at the moment, Public Health England have not actually changed their guidance. So there's a bit of a differentiation depending on which side of Hadrian's Wall you are as to whether it's an AGP or not at the moment. And that's an area of confusion we could really do without. Wilson, what do you count as AGPs in Hong Kong?
Yeah, at both universities, the University of Hong Kong and the Chinese University of Hong Kong, we have conducted experiment. And then we found that, well, first, the level of the viral load, even in the blood, was very low. And even more so inside the bone circulation. So our scientists in Hong Kong consider that even using high-speed drill and other power devices, it is not a genuine AGP. So they does not require the most stringent level of PPE, such as an N95 respirator.
Okay, very, very interesting. So that things may change over the next couple of weeks for practice in the UK, but I think it will be a bit of a risk in that England certainly of changing that until we've got a definitive statement from Public Health England.
Very helpful. We've had a lot of questions about testing. A lot of them have been around testing and isolation of patients. So if there's increased availability of antigen testing and we antigen test on the day of surgery, why do we need to be asking patients to do this very difficult self-isolation preoperatively?
The problem is we can have negative tests and they can still be getting COVID. So if they've had exposure to COVID in the week before or in the 14 days before, they may still be COVID PCR antigen negative, and they may then be symptomatic in the following week. And we know from the COVID surge paper that the rates of death are really very significant. So it's a worry. It's a huge worry. So I think we've got to test, we've got to isolate, and we've got to test.
James, what's happening in Bristol about staff testing?
So staff testing is open to all. It's an antibody test. If you're symptomatic, PCR antigen as well. Otherwise, it's just symptomatic, stringent hand hygiene and symptomatic assessment.
And how do we feel the antibody test informs how we should proceed?
Well, I think it was done really as a screening for the whole hospital, as much as anything to know where we were. That's all it does.
Phil, do you think it would have any influence on our ability to proceed going forwards, or?
No, because we know so little about what having antibodies actually means in terms of you and your risk. We don't know, so it doesn't change how you work. Again, we've all been tested. About, I think it's 15%, something like that, of our department have antibodies, but everybody is still working exactly the same way as they did before.
And in an ideal world, what would happen about staff testing for antigen, people working in a gold centre?
Yeah. So this, again, is a difficult one. James, I think you'll need to say what you've done with it in Bristol. It's to some extent facility dependent, and also depends on how quickly you can get your results back to some extent. My own feeling is that the ideal would be weekly testing, but the problem is about that movement, which is inevitable across blue and green sites. So you can test negative at the beginning of the week, but then you may well be exposed during that week. So it's a very difficult one. But what is absolutely key is doing the screening. So you've got to be sure that you've gone through every day. We insist every staff member coming into the green zone is temperature tested and ticks all the right boxes in terms of their potential for having been exposed or having COVID-19. So I think both James and Wilson, I think we need to know what you do about staff testing.
I'd completely back that up. We are not routinely testing because unless we're going to isolate people, I can't see how a one-off test helps. I know, unless they may be getting contact from spouses, siblings. There are all sorts of places that they could be getting positive results from. So agree with you, it needs to be symptomatic.
Is there any role for surgeons to self-isolate for a period before they do say if they book a suite of operations over the course of a week and self-isolate for a week or two before they start on that suite of operations?
Well, we did look at that, but we decided not to do that because it would have needed complete self-isolation for 14 days, and logistically we think that was just too difficult. And so instead we're going on masks. So any patient contact is masks, gloves, and plastic apron.
Yeah, thank you. And James, this is for you really, and also for Wilson, who you've got experience of patients starting through these pathways. Are you collecting data on the outcomes for your patients regarding COVID, and how's that being done?
Yes, we're collecting it as a local service evaluation. Through the academic unit, we have set up a list of criteria and we're collecting those.
And what's happening in Hong Kong, Wilson?
Yes, we are collecting the data on those patients who had confirmed that they're carriers, and we will perform the analysis once a sufficient number of patients are collected, and the data will be presented in international journals.
Yeah. The last suite of questions we've had have been regarding how we're going to recover our backlog of patients on the waiting list. And how we move forward with that. Wilson, you mentioned that there'd be maybe some weekend and evening working.
Yes.
And there was a question very directly about that, about who's going to pay for that? Any thoughts?
Yes, actually, we have this special honorarium scheme. So we would be hiring our own surgeons in the public hospitals to come back on weekends, as well as working late in the evening. Of course, the race has got to be, slightly more than at the normal hours. And then it is also up to the nursing team and also the anesthetist team that they may need to squeeze more time and give up some of their, entitled leave to work for that. So but we are trying to work out through these systems. The other way around would be to hire outside private practicing the locums, or actually we have been the so-called outsourcing some of the simpler or more straightforward orthopedic cases to the private hospitals. So we are acting in all possible manners.
And does the panel have a view on what impact the pandemic is going to have on the flow of orthopaedic surgeons around the world? There's quite lots of international medical graduates who want to come to the UK to do part of their training, people who want to go on fellowships around the world. Do we have an idea of how that's going to play out over the next year or so?
Yeah, I think that the questions of the impact of this on training overall are really only just starting to become apparent. So this is going to be quite some problem. But I think that this is a time where, the overall distribution of workforce is really important. And we will be, I'm sure, welcoming to IMGs to come and help with the training and to help with the backlog, which we're going to have. I think we can only beat this and come out of it with international collaboration. So that international theme is really important.
And when I look down the list of countries that our participants have registered from, it goes to show that this is very much a global pandemic and it needs a global effort, and that's what we're trying to work for.
Absolutely.
Yeah. So I'd like to take the opportunity to thank all of our speakers for a very illuminating evening. We've had a lot of questions. I hope I've managed to cover most of the major themes of the questions. I'd like to thank Phil Turner for being the driving force behind arranging this seminar. James, it's been great to hear of what's happening in the real world in the UK. And Wilson, your dedication staying up so late in Hong Kong and telling us what's going on really at the front line is brilliant. And we also got to thank the college administrative staff, Ryan, Abby and Heather, for their technical support. And then this wouldn't be a great webinar without our attendees and you guiding the questions that I've been able to put to our panel. So thank you to all those that have participated in the webinar this evening. Thank you.
Thanks very much.